Yesterday I told about CPAK classification. So I told about why CPAK classification is very important. So now, uh, because we are now respecting to the patient native anatomy situation. The situation means alignment and the joint line and ligament balances. Okay, but this distribution is quite different between the Western people and Asian people. For example, I compared this is LDFA and MPTF of the distribution. So minus value means birth. In the field of the alignment, minus values always means the birth, and plus value means the valgus. Okay, so this is the distribution on LDFA, tibial articular surface. The average is around 5.5 degrees in birth in terms of the tibial side. In terms of the femoral side, the average should be the 1 or 2 degrees. That's right, valgus. So, if we define plus minus 5 degrees as safe zone, so this safe range is temporal, not decided based on evidence, but based on our previous experience. Normally, plus minus 3 degrees is the practical, reasonable, but it is very narrow. So we always widen the safe range when we decided for mechanical alignment, for the kinematical alignment. So this range can be wider. Anyway, if we defined plus minus 5 degrees, most of LDF femoral joint line falls into safe range, more than 19 degrees, 90%. But tibia side, the more than a half patient come out of safe range. Well, this is a Japanese situation. So, of course, we can do at least with the femoral side. We can follow the patient native joint line. Yes, for example, so lateral side is 9 and medial side is 7. We don't have to adjust the angle because most of femoral joint line is come to within the safe range, but only the small percent. Most knee out of this safe range is the valgus knee. Some valgus OA patient have the very steep valgus ankylation in the tibial side. For these cases, we need to adjust a little bit to reduce the valgus because if we implant the femoral component to valgus, patellar group comes right to the medialized. Eventually, so patellar tracking and lateral reach of the femoral component can cause conflict. To avoid the one reason is to avoid the patellofemoral conflict. We should restrict the valgus alignment up to 5 degrees. What if we use metacuta sphericus? So patellar tracking is more forgiving because this group has 20 degrees of valgus. Anyway, we should take care about even the very small cases. We should take care about the too much valgus placement. わかる大体こそほぼここに入るんやけどさ。時々すごい外反の人が、ものすごい外反になってる人がいてて、その時にはあんまり 内反に、外反っていうか、に入れすぎたら、ね、あの、結局グルーブがこっち側を来てしまうんで、外側の壁で当たっちゃって、それで、まあそこでパテラとのコンフリクトを起こすやろうという、まああんまりせん方がいいかなっていうんですけど、少数ですけども、聞いてください。We should take care about too much valgus placement. The problem is tibial side. As I said yesterday, so this is still under controversial. We should accept these angles, or we should restrict it, these angles. Well, this is a different philosophy in the, between the true kinematic alignment, unrestricted kinematic alignment, and restricted kinematic alignment. But nobody knows the answer. But most surgeons worry about to place the tibial component the more than 10 degrees. There is no doubt. Because if you set positions the tibial component more than 10 degrees, the stem or key of the tibial component can touch to the lateral cortex of tibia. This is the same as the posterior slope. If you make the posterior slope too much, the stem can touch the anterior cortex. Or if you reduce the posterior slope, or even the anterior slope, the stem can touch to the posterior cortex. So the one reason is the mechanical. So mechanically, too much valgus can cause loosening. Another one is the design of the component. That is the one restriction because too much extreme alignment can touch the stem to the inner surface of cortex. This is another restriction. So, because of two reasons, most surgeons make a boundary in terms of tibia valgus alignment up to 5 degrees, or sometimes 6 degrees. It is quite reasonable. However, again, in Japan, around half percent, 50% of patient has very steep tibial joint line slope, medial slope of tibial line. If we reduce this angle to 5 degrees, maybe medial bony gap can reduce. Okay? So that is another problem if you do the restricted kinematic alignment. If you cut the bones parallel to the joint line, maybe after that, gap can be balanced automatically. But if you reduce or manipulate the bone cutting angle, for example, reduce the tibial cutting angle, medial joint line can be shortened. For example, normally we cut lateral 10 to the lateral side for the tibia, the 8 millimeter for the medial side of the tibia. And femoral side, 9 and 9. Eventually, we can get the 19 millimeter of medial space, theoretically. But if you reduce the patient, reduce 10 degrees to 5 degrees, maybe medial cut thickness can be thinner than the component. That can cause a medial tightness. So how to manage this one? The one technique is recut the tibia of slightly valgus. And another one is detached soft tissue. But for the kinematic alignment, so we should avoid the aggressive soft tissue release. So instead, most surgeons recut the tibia. Even the medial about the angle can be slightly steeper than this boundary. わかる？これを、ここでちょっと矛盾が出てくるわけよね。で、ここを、これが怖いから言うて、例えば5度に戻しましたと。そしたら、骨切り量がどうしても少なくなるわけですよ。本来の。理解しにくい。
いや、なんとなく。
脊椎の考えで思ったら分かりやすい。本当やったら、ね、10ミリ、8ミリ切れば、あれでしょ？コンポーネント厚さだけでしょ？こっち側はもう9ミリ、7ミリ。軟骨がないとしたら、切ったら、ちゃんとこっち側は、ね、8プラス7プラス2プラス2プラス2いうのは軟骨ない分。だったらちょうど10 19になるはずや。のバッチリのギャップになるわけだもん。もしもそれより骨切りが薄かったら当然きつくなる。で、結局それをどうするかっていうのが、またふわっとしてる。ただ、actually, even the tibial cut is thinner than the component. Eventually, gap can be balanced, almost balanced. Of course, if you reduce the tibial cutting thickness in the medial side, sometimes we should accept trapezoid bony gap. That means the lateral looseness or slight lateral looseness or slight medial time should be accepted as long as we restrict the bone cut alignment. だからまあどっちかよね。もうそうなったら、まあ、ちょっと内側がきつい、少し非平行なギャップっていうのは、あれセンター。まあ、ただ、for the unrestricted kinematic alignment user, I told with Dr. Howell, he never accepts media type gap. In extension, gap should be parallel in all cases. So they accept the steep tibia birth cut. But patients are quite different between our side, our patient and their patient. Basically, their patient is most patients have the type 2 CPAK. The CPAK type 2 is the most prevalent for their patient. But our patient, we are dealing the type 1 patient. So we never interrupt their result to our patient.
Yes.
Yes. So this is no conclusion. There is no conclusion. But another way is if we should respect the ligament balancing in extension, this is the one idea to cut the femur and then cut the tibia to get the parallel joint gap. So-called inline traction technique, or in other words, soft tissue respecting techniques. So femoral side is the major resection. Tibia side is gap balancing technique in extension. Oh, this technique is very, very popular in Japan.
Yeah. Dr. Yukiyama.
Yeah, Yokoyama, Dr. Soda,
Yeah, all of them.
Yeah. で、ここの角度は、脛骨に関してはこの角度を無視して、伸展で平行になるように脛骨を切るというふうな、まあ、日本ではよくされてます。まあ、これはやはりかなり極端な変形が多いという日本特有の、解決方法だと思いますけどもね。はい、というふうな感じになってますので。はい。あんまり興味なかったと。